I want to start by telling you a story. When I was training as a cardiac surgeon, one of my seniors operated on a patient who, for religious reasons, refused to have blood transfused. Now, in those days, there were no intensive care specialists, and so junior surgeons like me, fresh from a day's operating, or not fresh from a day's operating, had to look after the same patients in the ICU overnight. I had to care for this man who came out of the operating room already severely anemic because of how in those days we had to manage the heart-lung machine without blood. He was hemodiluted. He bled more when he got back to the ICU, at least in part because of low concentrations of clotting factors and platelets as his blood had been diluted. And we were not allowed to give him blood or blood products. All we could use were clear IV fluids, none of which were much good at transporting oxygen from his lungs to the tissues that needed it. His heart, weakened by the surgery, had to beat faster to pump these small amounts of hemoglobin and so the small amount of oxygen around. His organs began to suffer, notably his kidneys and his liver, and we became more anxious that his brain might also be oxygen deprived. Worse, he continued to bleed as his clotting factors were further diluted. He needed a blood transfusion, but we weren't allowed to give blood. His hemoglobin level, that's the way we measure the blood concentration, became ever more critically low. His lungs deteriorated as water and fluid leaked out of the tissues, leaked out of the circulation into his lungs. They got stiffer, and he started to go into renal failure. Those of us who were in the ICU were spending almost all of our time with him, and we were struggling to care for the rest of our patients that night. His family were adamant that he should not have blood, and the consultant who consented the patient for surgery was called at home and confirmed during the night that yes, that was the case. We were not allowed to give blood. Everyone working in the ICU was finding this situation difficult, almost unable to comprehend how someone could hold such strong beliefs that they would allow themselves or their loved one to die, which seemed to be the inevitable consequence for this chap. However, the family were completely secure in their belief. Indeed, they were disconcertingly calm. Accepting blood was worse for them than refusing it. It meant, they led us to understand, eternal damnation. Not only were we uncomprehending, but also we were frustrated and angry and desperate. We knew we could make this guy better, and we could make him better pretty quickly if we gave him blood. Indeed, we thought it was our duty to do so. We had the skills, the tools, the resources, but we couldn't use them. We weren't allowed to give blood. Amazingly, he didn't die. But he did have to stay in the hospital for weeks, anemic, prone to infection, and with very slow organ recovery. Clearly, the cost to him and to his family were huge, but they were huge to the staff as well, and in a way, financially to society. His long stay in the hospital prevented several other people from having access to a bed and hence treatment. And during that time, relationships with the family were sometimes quite tough. Several members of the staff resented that the consultant had agreed to the patient's demands in those days without wide consultation. Now, we were really glad eventually to see the patient go home. Proud, in fact, that we'd somehow got him through this. But others had not been so lucky. The family and this patient had a very strong belief. And we felt we had a duty to make him better. And we could do that with blood. What I want to discuss for the rest of the talk is where that belief comes from, some of the implications for those who care for them and for the person who bleeds, to talk about the safety of blood, some lessons we've learned, and finally a little bit about the law. Blood is the most fantastic courier system that we've got. It carries particularly oxygen and nutrients, but also cells and antibodies that fight infection. It collects and delivers waste products to recycling centres in the liver and the kidneys, and carries stuff in the form of platelets and clotting proteins which can seal up holes in blood vessels. And working with those blood vessels, it can redistribute blood to even out your body temperature. It is a vital life-supporting fluid. We'll keep that definition in mind. You've got about, in an average adult, you've got about 5 litres of blood in your body. It's about 8% of your body weight. Just under half of it is cellular, made of mostly red blood cells and some white blood cells and platelets. And the rest is plasma, dominantly water with dissolved proteins, ions, nutrients, waste products, and gases. An unavoidable consequence of major trauma or surgery is cutting or damaging tissue. And if you cut tissue, it bleeds. And although our surgical techniques have improved considerably over the centuries, that bleeding can be life-threatening. Now, most of the bleeding we come across can be stopped by using cautery, diathermy, or by tying ligatures around great big blood vessels, or by compressing. But if a larger vessel tears, or if a wider surface is bleeding, then these techniques can be overwhelmed, and without additional treatment, the patient just simply exsanguinates and dies. Now, we've learned over time that lost blood can be replaced, and it can be replaced by clear fluids like saline or other intravenous fluids, synthetic colloids, or, of course, blood and its components. And actually, that's a major part of what an anaesthetist does while the surgeon's operating, is trying to make sure the fluid balance is correct. This is crucial during resuscitation, and it's crucial to trauma victims, crucial during surgery, and of course, crucial in massive trauma, as we've seen in many war zones, sadly, recently. As a doctor, as a surgeon, my primary duty, is to save the life of the patient without doing harm. If bleeding exists, and I can't stop it in any other way, the existence of blood for transfusion should be a lifesaver. Now, bloodletting has been around since the time of Hippocrates, but blood transfusion has a much shorter history. Now, I haven't got time to go into the detailed history of blood transfusion, but I have included in the essay which accompanies this, and which you can collect on the way out, a much longer and referenced history for you to read. But Gresham College actually forms part of the history of blood transfusion. Samuel Pepys, in November 1666, came to Gresham College to witness an experiment being carried out by Richard Lower from Oxford, who had carried out the first dog-to-dog blood transfusion. And this is what Pepys wrote. Basically, they connected up 2 dogs, one to the other, and they allowed one to exsanguinate into the second dog while the second dog bled onto the floor. The first dog died, the second dog lived. And Pepys recognized that this was really quite remarkable. Apart from the idea that you could transfer the blood of a Quaker into an archbishop with interesting consequences, he also recognized that it would have potential medical significance. I didn't bring my dog tonight, I'm glad to say. It wasn't until the early 19th century that human blood was used by syringe, and that was used to treat casualties in the Franco-Prussian War without cross-matching. And James Blundell, who was an obstetrician, reported human-to-human transfusion as a life-saving procedure after childbirth in the aptly named Lancet in 1828. There was no attempt at cross-matching blood, because it wasn't until 1900 that Landsteiner discovered the 3 major ABO blood groups. He was awarded the Nobel Prize for this in 1930. He probably deserved it because he also identified the polio virus and also went on to identify the rhesus factor blood group in the 1940s. Blood groups matter. If you're transfused, you must be given compatible blood. So if you have group A blood, you have A antigens, proteins on the surface of the cell, and circulating in the blood, you have antibodies to the B proteins. If you have a group B, you have B antigens on your cells and antibodies to A, and so on across the piece. That means if you transfuse type A blood into a type B person, circulating in the blood are antibodies to the A antigens, and they stick those cells together, agglutinate them, and then the body lyses them and breaks them up. So you destroy the cells by this auto-agglutination method, which is a transfusion reaction. Blood transplantation and donation in this country is now managed by NHS-BT, NHS Blood and Transplant. This collects 1.7 million units of blood a year from 23,000 sessions and 3,000 venues. And even now, after good anticoagulation and refrigeration, red cells only last for 35 days, platelets for 7 days. You need a constant top-up. And you particularly need a constant top-up of O negative blood, which is the universal donor, and that's useful for anybody in trauma when you don't have time to cross-match. That means we need 6,000 donations of blood a day. And in fact, much to my surprise, I discovered that less than 3% of people in this country aged between 17 and 70 have donated blood in the last 12 months. Check your donor cards, please. So I think you can probably understand already that blood saves lives, continues to save lives. Why on earth, if that's the case, would you refuse to have it in the form of a transfusion? What is it that would allow you, make you, to want to say no? And for the surgeon, as one other surgeon famously put it, operating without access to blood is like operating with one hand tied behind your back. So for me as the surgeon, I'm also put in a difficult position. The belief that you shouldn't have a transfusion is if you held dominantly and proselytized by the Jehovah's Witnesses. And the Jehovah's Witness Brotherhood grew out of the Watchtower Society, founded around 1880 by Charles Taze Russell. Russell was born in Allegheny, which is now part of Pittsburgh. He had a mainstream Christian background, but for a while lost his faith and explored Eastern religions. And in common with many religious organizations, as Chrysides pointed out, there's a prehistory. For Russell, it was growing up at a time when Adventism was dominant in the early and later 19th century. Adventists, as you know, believed in Christ's second coming, which they expected to happen in their lifetime. In common with many people at the time, they were of the view that they could calculate the exact year that this would happen from intensive Bible study, looking for complex numerical clues hidden primarily in the texts of Daniel and Revelation. Sadly, these calculations often proved wrong. And in 1843 was the first one. It became known as the Great Disappointment. But despite these failures of predictions, the beliefs of Adventists have found fertile ground. The churches have split into all sorts of branches, as we'll see in a minute. But by 2010, there were 22 million members in the world subscribing to this faith. And that included Russell's Bible students from 1880 onwards, who grew in number, and under his successor, James Joseph Franklin Rutherford, morphed into Jehovah's Witnesses in about 1931, with an equal emphasis on the truth residing in the Bible. Now, the commitment to Bible study and to specific interpretations of the Scripture was combined with an equally strong commitment to evangelism, which you probably recognize from the door-to-door techniques for which Jehovah's Witnesses became famous in the 20th century particularly. I rather liked hearing about this because the people who did the visiting were carriers of the message, and they were called coal porters. which I must say I thought was a composer. I was quite pleased to find he was something else. Now, Jehovah's Witnesses are less frequent on your doorstep, but they are very common outside the tube station. And as The Guardian put it, busy heathens are rarely at home, so it's a good place to catch them. The witnesses have been enthusiastic and effective early adopters of new technology. They were the first to use multimedia presentation in an 8-hour, 4-part religious film called The Photodrama of Creation. A fantastic set of images. It cost $300,000 to make in 1914, and if you redo the sums for this era, that's $7.25 million. It had already proved to be a very effective fundraising operation, willing to spread its word. I thought it would be interesting to hear the tone of that lecture.
God's glory in the heavens. The reverence of Jehovah is the beginning of wisdom. Only the foolish say in their heart, there is no God. Day unto day uttereth speech, and night unto night showeth knowledge. The heavens declare the glory of God. An appreciation of the infinite power of the Creator and of our own littleness should make us teachable. The study of creation is the key of knowledge. Using this key, we begin to realize that the only worthy ambition is to cooperate with our Creator's beneficent designs respecting His creation.
It's not quite a lost oratorical style. You can still hear people at street corners, not necessarily Jehovah's Witness, using the same rhythmic sounds. It's a very interesting delivery, but that goes on for 8 hours. You can see a 3-hour version of it on YouTube. Jehovah's Witnesses were the first to use radio as an evangelical tool, right up until 1957, and they have a huge and impressive web presence at jw.org, which is extremely informative and has a great depth to everything that's proselytized. And in 2014, they set up web-based internet television with an equally large audience. Now, the JWs have grown, unsurprisingly, if you think about that method of delivery of the message. In 2016, there were 140,000 Jehovah's Witnesses in the UK, but globally, 8 million in 119,000 congregations in 240 countries. That's a lot of people who don't want blood. So why won't Jehovah's Witnesses accept blood? That's essentially the key question. Fortunately, the website and many of the Jehovah's Witnesses that I've spoken to have been very clear about it. The Bible commands that we should not ingest blood, and we should not accept whole blood or its components in any form, either as food or as a transfusion. And the texts on which this is based are these. Genesis 9:4, which I'll let you read. This command applies to all mankind from that time onwards because we're all descendants of Noah. This is the Jehovah's Witness commentary to that quotation. From Leviticus, God viewed the soul, all life, as being in the blood and belonging to him. And although this law was given only to the nation of Israel, it shows how seriously God viewed the law against eating blood. In a recent translation from the Hebrew, blood should also be translated as life, the life force. That's different from what I defined it earlier as something life-sustaining. This is the life force. And finally, from Acts, God had given the Christians the same command that he'd given to Noah. History shows that the Christians refused to consume whole blood or even use it for medical reasons. So there, a crystal clear message in terms that we should not use blood. Now, these beliefs are profoundly held and a core value to the Brotherhood. Any non-consensual transfusion is regarded as a gross physical violation. Even pre-donation, in which your own blood is removed, stored, and then retransfused later, is unacceptable. Now, as I implied earlier, people have died as a result of this decision. It's actually incredibly hard to work out how many. There's no register kept of that. And although many attempts have been made to find the number based on reported cases and the incidence of surgery for particular procedures, it's difficult to get a true number. The most widely quoted estimate comes from a 1993 paper looking at surgical outcomes in Jehovah's Witnesses. And it comes to an astonishing 9,000 predicted deaths a year, which I just think is way too much of an overestimate. And for reasons which will become clear, I think those numbers should be declining. But death on that scale, or even predicted death on that scale, is bound to create debate, ethical debate, both internally within the church and externally without it. This is a recent development as well. The decision to say, or the references to the Bible at this point, come from 1944 and 1945. So that it's not an old belief, it's a belief that emerged through the Watchtower, the House magazine in 1944 to 1945. Now, despite internal debate and external criticism and actually multiple lawsuits during that time, the position of Jehovah's Witnesses remains absolute. It was reported, though, in 2000 that church elders in New York had voted to allow members to accept blood transfusion in critical circumstances, provided that they repented afterwards. As you can imagine, this was greeted with some surprise, not only outside the church but within it. Countless thousands of the relatives, the Guardian said, had been allowed to die needlessly, and they would be angered by this because it had been changed by, quotes, a bunch of old men hiding in a room in New York, and they must be terrified of litigation. Almost immediately, the church clarified its position in a letter to the Times in June 2000 from the Jehovah's Witness Public Affairs coordinator, and said this: if a baptized member of the faith willfully accepts a blood transfusion and has no regrets, he indicates by his own actions that he no longer wishes to be a witness. The individual revokes his membership by his own actions rather than the congregation initiating the step. Now, this needs to introduce two other terms, disfellowship and shunning. I'll define them in a minute. But blood transfusion is on a specific list as an indication for disfellowship and shunning. It comes somewhere between bestiality and drunkenness on that list on the left-hand side. A person may be shunned by the community in which they live and with whom they've built up an entire social life. It's also called disfellowshipping. And it was aimed at those who are unrepentant wrongdoers. There are people in the audience tonight who can define that much better than I can. But it was regarded as a loving provision to make sure that you remained within this caring community of the church. Being cut off from the community you've grown up with and shared so much must be very, very difficult to bear. And you can find many stories from people who've left the Jehovah's Witnesses who can explain this better than I can on the internet. Some of those quotations are here. Those that continue to believe in the Watchtower doctrine and told that whilst disfellowshipped, they're condemned to everlasting damnation. And those who become unbelievers with no intention of coming back realize that they're unlikely ever to freely associate with witness family and friends for the remainder of their lives. Now, in conversations I've had in preparing this talk, this seems to be an extreme interpretation of that. People are allowed back into the church after they have lapsed, if you like. But the belief is profound. And if you are concerned that you are going to have everlasting damnation, you start to understand why you might want to refuse blood. But let's look at it a different way. Maybe they've got a point. Maybe we should all be refusing blood. How safe is blood? I've told you a story so far that bleeding kills and blood saves, and both of those are truisms, but of course it's not that simple. I've also pointed out to you that being transfused with incompatible blood produces a transfusion reaction, which can be very dangerous. In this country, there's an organization with a wonderful acronym, SHOT, which is Serious Hazards of Transfusion. And they collect all the data relating to adverse transfusion events and publish an annual report that you can find online if you'd like more detail. The annual rates of reporting adverse events over the last 4 years are here. That's 15.4 reports per 10,000 issues of blood components, 10,000 bottles, if you like. That's 0.154%, a very low incidence of reported problems. And what makes up the most common cause is errors. Errors in labeling, errors in laboratory cross-matching, errors in delivery of the blood to the wrong patient or the wrong blood group. That's out of 2.25 million issues, 1.6 million issues of red cells. Human error, under-transfusion, delayed transfusion, avoidable transfusion, handling and storage errors, immunoglobulin errors, and very rarely incorrect blood component transfusion. There were 26 deaths, of which the majority, at the bottom, over here, sorry, I've got on one slide, haven't I? Let's go back, of which the majority were delays to transfusion, or this one, which is a transfusion overload, giving too much blood. It's very rare to have a death from an infection or an incompatible blood transfusion, one patient each. But they're still deaths, 26 deaths. I don't know how many people died in the Jehovah's Witness Church from refusing blood in the same period. It's not just death. There is serious harm from acute transfusion reactions and a lot of other things that don't really warrant discussion, but it's a risk of serious harm of 1 in 15,000 components issued, overall risk of death in 1 in 100,000, but a risk from a death from an error of 1 in 300,000. Blood is not completely safe, and it should only be utilized when it's vitally necessary to mitigate the risks that you're being presented with. It's not very dangerous, but there is a risk associated with giving it, and that's important for all of us who work in medicine. So the next thing we need to do is to avoid the need for it altogether. How do we do that? Avoiding blood might actually be a good thing. And as a surgeon, I want to try and discuss that in relation to my work, before surgery, during surgery, and after surgery. Because if I want to operate on someone who's a Jehovah's Witness, I've got to have a cunning plan of how I'm going to do that if I'm not going to use blood. Before surgery, I first of all want to consider avoiding surgery at all, make that plan, and then communicate it. During surgery, don't let it bleed, stop the bleeding, and then retransfuse or do something to restore the circulation to a good state. And afterwards, monitor, stop the bleeding, salvage losses, and then make the bone marrow produce more red blood cells. We'll go into those in a bit more detail. Let's start with before the operation. John Kirklin was one of the best cardiac surgeons the world's ever seen, and he, despite that, said if there's something other than surgery you can do, it's usually best. The most important consideration is to try and avoid surgery if you can, by considering and discussing alternatives. Is there a drug that would do it? Is there another treatment? Is there something I can do in interventional radiology rather than surgery? And even if surgery is decided upon, we've got to ask ourselves, how invasive do I need to be? Could I do this in an endoscopic way with little telescopes? Minimal access surgery. And that's grown hugely in the last 20 years, as you know. And when you do that, the number of vessels that you cut and the potential of bleeding should be markedly reduced. Many people are on aspirin or ibuprofen, for example, for various conditions. You should stop those drugs because they're more likely to make you bleed perioperatively. And you should check the baseline state to see how anemic you are before the operation starts. It's no good taking you to the operating room if you're already anemic without having done something to try and correct that, if at all possible. that possibility is that it's sometimes wise to prepare a patient for surgery in a more intensive way. And apart from the standard recommendations like quit smoking, lose weight, drink less, eat healthily, it may be possible to increase the amount of blood that you produce and increase your hemoglobin by giving you EPO, erythropoietin. EPO is the drug that you'll have read about that athletes cheat with and cyclists cheat with by having an infusion so that they can have a higher oxygen carrying capacity when they undertake their exercise. But to be eligible to have EPO, you have to have a hemoglobin below 13 grams, normal is about 15 for a man and about 12 for a woman. Normal for a woman is about 14. And there are some specific circumstances when its use is contraindicated or constrained. If you give erythropoietin, you upregulate the way the bone marrow is producing red cells, and you start to eat up iron in order to make hemoglobin, and so you often have to give intravenous iron at the same time. Erythropoietin is expensive, and it takes a course of a few weeks to raise your hemoglobin to a normal or slightly above normal level before surgery. Now, plan and communicate seems obvious. The detailed of the planning that I want to do to be able to operate on a Jehovah's Witness without the use of blood must engage all of those involved in the care. If you remember from the story I gave you at the beginning that there was a creeping resentment amongst the team because they hadn't been asked very well in advance about whether they were prepared to get engaged in this work of operating with one hand tied behind their back. It should include the whole surgical team, the anaesthetist, all the nurses in recovery. There are a team of 28 people very often in a cardiac operating room, as well as all those who care for them afterwards. It can take up a lot of people's time and commitment just to have the debate and decision-making that this is okay to do. And planning must describe all stages of the procedure, not just the operation itself. Surgeons often have a very blinkered attitude of what their work entails, just involving the operating room, and hope that others will sort things out afterwards for them. But that's not the case. This is extending the care over a period of time. So you have to communicate your plan. And by far the best way of doing this is to hold a detailed multidisciplinary team meeting, including all of those people I mentioned. Everyone who might encounter the patient and who might give blood. Anybody who is in that position must be aware of the plan, and the plan, of course, must be written down and agreed and signed up to. MDTs are expensive. Imagine getting 25 to 30 people in a room to plan this when they've got other things to do as well. If you price it per hour, it's not cheap. But it may well be cheaper in the long term than managing a patient for whom no effective plan has been made. What about during the operation? Well, there's quite a lot that we can do, but the most important are very simple and basic rules. Be gentle, be careful, and be obsessional. We've moved a long way since I became a surgeon, and in those days when I started, the whole process was driven by speed. Being in the operating theatre, being on bypass, and indeed to some extent being under anaesthesia, were considered to be dangerous. And if you were a fast surgeon, you were a good surgeon. Nowadays, people are, it's not so dangerous, and anaesthesia is way, way better, and the equipment we use is way, way better, and we can take much more time. So the new generation of surgeons coming in are gentle, are careful, and are obsessional. And our kit has got so much better, even simple improvements in sutures where they're very much thinner and sharper and stronger, and the sutures that attach to them are about the same size as the needle, so they don't leave a big hole behind them when you put the suture through the skin. We have bright lights and magnifying glasses so we can do our work with greater precision and tolerate less bleeding than we used to do in those early days. New kit comes along all the time. I've talked about diathermy, electrocautery to cauterize small vessels, and we use and place ligatures around the larger ones. But we've seen the introduction of things like the harmonic scalpel, which is an ultrasound device which cuts and coagulates at the same time by burning the tissue just in a tiny distance using high-frequency ultrasound. But perhaps most useful, though, is this, which is called the cell saver. If I make a patient bleed and the blood accumulates in the wound, I can aspirate it. So here's the patient. The blood that is leaking out can go out to a reservoir and then gets mixed with some saline and washed, goes to a centrifuge to spin out all the red cells. The water comes out, and then you can pump the red cells back to a bag and then reinfuse that into a patient. So in a very closed circuit in the operating room. And this is the machine. There's the reservoir. Here's the bag you collect the blood in, and the centrifuge is in this bit. The next thing we can do during the operation is to sort of fiddle around with the clotting mechanism. Now, blood clotting is a complex process involving the activation of those circulating platelets and a whole cascade of chemical reactions which don't project very well on the right-hand side. They result in the platelets and those reactions produce a mix of fibrin and platelets which plug the hole in the blood vessel. And at the end of that time, as the body is healing up, that fibrin can be broken down by a process called fibrinolysis, controlled by something called plasmin. Now, Jehovah's Witnesses resolutely decline the transfusion of whole blood and primary blood cell components, that's red cells, white cells, plasma, and platelets, and the use of any sample of blood for cross-matching. But many will accept the infusion of these clotting factors. So if blood clotting is a problem, and for whatever reason, then you can give some of those clotting factors, factors 7, 8, 9. And there are drugs which interfere with that fibrinolysis process, the dissolving of a blood clot, by blocking the action of plasmin with the breakdown of blood clot at that point. The most commonly used one is called tranexamic acid, which is now used very commonly in cardiac surgery. And we used to use a drug called aprotenin very frequently, but that had started to have some abnormal side effects on the kidney and the brain and is now almost abandoned in adult practice. We still use it in newborn babies where it's extremely effective. We can also use tissue glue, a fibrin glue, where we mix human fibrinogen and aprotenin in one syringe with human thrombin and calcium in another, and they get mixed together to create something like the picture on the right-hand side, which is a synthetic version of a normal clot. And by mixing those together at the operating field, you can seal up a number of holes, and you can spray it onto an oozing site. Or we can lay on some oxidized cellulose as a little membrane over an oozing surface. So there are practical things we can do in the operating room. But nothing beats taking your time. There's no substitute for dealing with every small blood vessel. A little can add up to a lot. And it's important in all cases and vital in patients who refuse blood. Just reducing the amount of blood samples that you take during and after the operation can also make a difference. But time is the critical thing. And so important is accepting a degree of anemia. How anemic can a patient be? Current evidence suggests that it's very unsafe to go below 7 grams per deciliter. That's about half the normal blood level. You start to have very bad side effects below that level, and the mortality rate begins to rise quite quickly. So you should be trying to keep the concentration as high as possible. So if you give erythropoietin before and use all these methods, you may well be able to tolerate much more blood loss than you would have thought possible. What about afterwards? Well, the principles are quite simple. You have to watch what's happening by measuring the normal physiological variables like pulse, blood pressure, and so on, or watch what accumulates in the drains that you see by the bedside in people having operations where blood is actually being drained out of the wound. We can go back to the operating room to stop any bleeding if necessary, or use one of these cell savers to reuse that blood by the bedside. And we can stimulate the bone marrow by EPO or by giving vitamin B12 and iron to restock that patient's supplies. All of this will allow recovery to take place in the absence of blood. Now, I'm a cardiac surgeon, and the example I told you at the beginning was about cardiac surgery, and I need to explain that that is a little bit different. We use cardiopulmonary bypass. And that means that you're connected to a heart-lung machine. There's the patient and here's the heart-lung machine. Blood drains out of a patient into a reservoir through an oxygenator and then get pumped back into the patient. And there are various other suckers and filters that you require in order to create that. The machine is connected to the patient and the circulation by a series of plastic pipes. Now, let's see if I can make that work. Those pipes here, connected to the patient and pumping around, are filled with blood and fluid. When you get them out of the packet, they're empty. There's no blood or fluid in them. And if you connected up to the patient in that empty state, you would pump air into the patient and it would be fatal. So you have a machine which has a volume which needs to be filled with a fluid before you join it up to the patient. It has to be primed. So let's imagine that you have a patient which has a volume, a circulating volume in red, and a pump which has an equal size circulating volume there. If I mix the two together, I've primed the one on the left with clear fluids like saline, and the patient is on the right, then the patient will be hemodiluted. They will distribute that blood equally between the two components as it pumps around. It gets a bit more difficult when the pump stays the same size, but the thing you're connecting to is a small baby. Then, when you join them up, the degree of dilution is much, much greater. And so you have a patient, a child, who is really seriously hemodiluted. And when we started to operate on small babies, this was considered to be something of an advantage, actually, because it allowed you to cool the baby right down to 18 degrees centigrade and protect, inverted commas, the brain during the time that you were operating on them. Severe hemodilution. Now, during the 80s and 90s, the age and size of babies that we were able to operate it on came down to newborn baby size, 1, 2, 3 kilos. And we could only do that because the equipment got better, our knowledge of what was wrong with them got better, and our techniques improved. The procedures that we could perform became increasingly complex at the same time, and they took longer. And it was discovered at about that time that if you expose this baby's blood to this enormous surface area of the pump that you've just seen, there would be a giant inflammatory response. And the inflammatory response would cause the blood vessels in the baby to leak. Water would leak out of the circulation into the baby, and they came out of the operating room swollen like a Michelin baby. They were not only swollen to look at, but their organs were full of fluid, and they were stiff, and their lungs didn't work, their hearts didn't work very well, their kidneys didn't work very well, and anybody in the audience who's ever worked with these babies will remember how hard they were to look after in the 1980s. This is when I became interested in it, and why I wanted to talk about this, because working in Newcastle first and then at Great Ormond Street, we worked out methods to measure the amount of water that you had in your body using bioimpedance, total body water. And we were able to demonstrate with Tada Meihara, who is Professor of Surgery in Tokyo now, that the amount of water that you have in your body after a period of time on bypass with low temperature and low hemoglobin rises. And the more it rises and stays high for up to 3 days post-operatively. And the longer you're on bypass, the smaller the baby, and the lower the temperature, the more water you got. So the fatter and wetter the baby became, and the worse the function became. Now, what we did was to develop a method of using this, which is a thing called a hemofilter, which came originally from dialysis, which allowed the blood to go through tubes of a semi-permeable membrane and allowed water to leak out. And by changing the flow rates and the amount on each side, you could alter the amount of water that you were able to withdraw. And we did it in such a way that you could drain the excess water from the baby, but also hemoconcentrate the pump. And this is a summary of what we found. Over about 15 minutes, we could raise the hemoglobin from 20, hematocrit from 20, that's half what it normally is, up to 35, close to normal, in 15 minutes without giving any blood. This is just taking all the water out. And if you start from the baseline position, we ended up with a 40% rise in the cardiac output, a drop in the heart rate, and it became much easier to pump blood through the lungs, pulmonary vascular resistance. This is exactly what you want to do when you give loads of drugs at the end of cardiac surgery. It's exactly what you would want to see as a result of blood transfusion. It's exactly a good output, and we hadn't given anything. We'd taken water out of the baby. And we were able to demonstrate this lots of times. It's now, it's called modified ultrafiltration, and it's used in adults and children's open heart surgery worldwide to save blood, particularly in the adult sector. It reduces bleeding too and improves the heart's contractility, and I wish I had patented it. It was a very big mistake in my career. Less blood, less bleeding, better performance for adults and children. But what it meant was, as this news sneaked out, was that I worked out that we could perform heart surgery in children with almost no donor blood, and in fact without it in many cases, above a certain size. Unsurprisingly, perhaps, I began to get consulted by many Jehovah's Witnesses families from around the UK, and I started to ask myself if blood should be avoided for everyone, and not just Jehovah's Witnesses, maybe we would make a better fist of things if we avoided as much blood as possible. And we actually now can operate and do operate with clear primes, smaller prime volumes because the machinery's got better techniques, and a greater degree of confidence that we can avoid blood. And it was at about that time, this is the 80s, early 90s, that I came across the hospital liaison committees. And it created something that I'd never had before, which was an opportunity for constructive dialogue with a group of people who had deeply felt beliefs, and whose liaison committees, which started in about 1988 and had arisen from something the Jehovah's Witnesses call the Hospital Information Services. And they'd maintained a watching brief on the literature of how to do surgery without blood for a long time, since the 50s and 60s. And they had a growing list of surgeons and physicians who were willing to undertake surgery in Jehovah's Witnesses. Their website, by the way, if you want to go to it, has an excellent series of links to all the relevant medical literature and is an example of how it can be presented. Now, I know that there are several members of those committees here tonight, and without wishing to praise them excessively, I can honestly say that they have always been incredibly well informed, very helpful, and are excellent arbitrators. Without them, many of the relationships between doctor and patient would have failed. Jehovah's Witnesses carry advanced directives if they're adults. Advanced directives, which is a decision card indicating their express wish that they should not have blood or primary blood components. Now, as a surgeon, by agreeing to operate under these conditions, one in some ways becoming a willing participant in their belief. And it seems to me subtly different from the right that was established in 1961, that you have the right to kill yourself as a human in this country. And the surgeon in some way is engaged in this decision by accepting that. I started this lecture by suggesting that there was a conflict between the beliefs of a Jehovah's Witness and my duty as a doctor, and it's not as simple as that. But the law is clear. Lord Justice Mostyn described these beautifully in a recent judgment. Every citizen who is of age and sound mind has the right to harm, or since 1961, to kill himself. This comes from the Declaration of the Rights of Man and Stuart Mill's essay on liberty, which I'll let you read. You have sovereignty over your own life and body. In another judgment against St. George's, even when his or her own life depends on receiving medical treatment, an adult of sound mind is entitled to refuse it, if you have capacity. There's no obligation on a patient with decision-making capacity to accept life-saving treatment, and notably the doctors are neither entitled nor obliged to give it. The clarity of the law has had equally clear expressions about my duties. I'm duty-bound to respect, for example, the Jehovahs Witnesses' religious freedoms. But I have the right to choose not to treat them if I don't want to, because they're too much for my values to bear. But if I am unwilling to treat them, it is also my duty that I must try and pass them on to someone who is, if I can find them. What about children? The UN Convention of the Rights of a Child defines a child as anyone under 18, with a legal age of consent in this country of 16. The power to withhold consent for medical treatment for a child lies with parental responsibility, and the parental consent is legally necessary to perform any medical procedure on a child. Parents have the right to raise their children as they see fit, and they have religious freedom. And of course, both these arguments have been used by Jehovah's Witnesses defending their right to refuse blood on their child's behalf. But the parents' rights are also qualified by their own duty to ensure their child's health, safety, and well-being. Now, we have to remember it's quite hard to become a Jehovah's Witness. Baptism only occurs after a prolonged period of Bible study and training. And whilst you're being raised within the brotherhood, it is up to the individual to decide for themselves whether they accept the teachings. Ultimately, each person must make his or her own choice. But there was a classic judgment in 1944 in the US, which is frequently quoted, that parents may be free to become martyrs themselves, but it doesn't follow that they're free in identical circumstances to make martyrs of their children. This business of whether the child is or is not, if you like, a Jehovah's Witness or has not capacity is very important. In a child under 16, in this country, four main issues arise: whether the child's capacity to consent to treatment, parental authority and its limitations, whose view prevails when parents and children clash, and the extent of the court's power over adolescence. Classically, this is discussed in the case of Gillick versus West Norfolk, where three issues were met by and holding with the House of Lords held that these were the situation. If a child under 16 could demonstrate sufficient understanding and intelligence to understand fully the treatment proposed, they could therefore give consent to that treatment. If they failed that competency test, in other words, people judged that they hadn't understood it, then parental consent was required. Now, what's important about that is that the Gillick judgment, did not consider refusal of treatment, only acceptance of treatment. And it's become known as Gillick competence. Is the child Gillick competent? And logically would have thought that a competent child should be able to refuse as well as to accept. But actually, several cases on, that hasn't been the case, and the court will intervene if the child's welfare is threatened by serious and imminent risk, that the child will suffer grave and irreversible physical harm. When treatment refusal was religion-based, there was concern about the child's freedom of choice in the context of their upbringing. And thus, while a child's refusal to have treatment should be considered, it is likely that the court will override the refusal in the child's best interests. Now, it's my view and my duty that we should do all we can to respect the firmly held views of the parents and the wishes for their children. We've learnt that it is possible to perform complex surgery without the use of blood, and the evolution of that learning, I would say, is in no small part due to pressure put on the profession by Jehovah's Witnesses, trying to find a way to help them. Working with the liaison committees, we have developed detailed understandings. We have understood that we can make workable plans to avoid blood in individual circumstances, usually on the basis that the medical team working with children will do everything in its power to avoid the use of blood and only give it in an absolutely dire emergency. But that is an agreement because the child may or may not have competence. If there is time to consider, and if agreement with the family cannot be reached, even with the help of the liaison committees, then we do go to court to allow those who we pay to make difficult decisions on society's behalf to apply their considerable intellects to the problem in an environment which is freer of the emotions which are unavoidable to those working with the child itself. Going to court is mercifully rare because we're getting much better at minimizing the use of blood, and the hospital liaison committees understand our position, and we work very closely together to negotiate our way through that complex environment. I led you to believe in the title of this talk that I perceive the relationship between those who refuse blood on the one hand and those who have to give it on the other for medical reasons as one of warfare, a battle. My own research at one time placed me absolutely in the firing line of that battle. And as I met more and more Jehovah's Witnesses, I kept finding better and better ways of reducing the blood requirements for cardiac surgery. And I hope I've convinced you tonight that it has proved not to be a battle, but rather the development of a mutual understanding. And we've ended up in a similar but not identical place. It is a good idea to minimize the amount of blood you give your patients. And the pressure from witnesses has undoubtedly driven many workers across the world to find alternative strategies for avoiding blood and for treating bleeding when it occurs. These strategies have proven successful and are now not limited to benefit for Jehovah's Witnesses, but for everyone. And I think wider society, paradoxically, owes them a debt of gratitude. But we are only in a similar place. For non-believers like me, it remains really difficult to comprehend that life-saving and on the whole extremely safe treatment is refused for ideological reasons. As Woolley pointed out just over a decade ago, religion is a powerful persuading voice, but in the end it's also an individual belief. And a limited life experience cannot truly give one the opportunity to rationalize a belief that may eventually lead to death. This is the core challenge for all of us in this room meeting this question head on. The belief is clear. It is absolute and profoundly held. My duty has been clarified over time, both by consensus and by the courts and with the help of the colleges. I must respect the beliefs of my patients and do everything in my power to abide by them. The hospital liaison committees, well-informed and caring as they are, facilitate these discussions. An agreement is usually reached. Resorts to the court is rare. A competent person has the right to refuse treatment. If I cannot support their decisions, my duty is to refer them to someone who will carry out their wishes. I can leave the battlefield, but the believer cannot. But they're going to feel secure in their belief that by refusing their blood, they are, to parody the argument, going to be accepted in a better place. Sadly, those of us left behind after trying to care for them are unlikely to be so certain. Thank you very much.